for where we think the patients can benefit. So I think today's form, we're going to be having 3 sessions. It's divided into 3 sessions. I'm going to request Imran Abbas to explain to us just the house rules today's, as well as tell us how these sessions are going to be run before we kick off with them. My request to all the participants would be, please keep yourself muted unless until you are talking, so it'll be easier that we won't get any interference. Many thanks.
Sir, so much
Imran,
thanks.
Please.
Yeah, sir, this session today, because this will be for 3 hours till 10 p.m. Dubai time. And we have divided, because on the base of my interview, we divided in 3 sessions. One part is sleep plus. What means sleep? Those who are doing SASI, those who are doing SADI, they will be in first session. And its first session, our expert panel will be Professor Sergio Santoro, Professor Ario Di Paula, Professor Tariq Mehdi, Professor Antonio Torres, Kazama Kazaroni, and Professor C.K. Wang, and Professor Carlos. So they will be expert panelists, and our moderator, Professor Asim Shabbir, Professor Hassam, Professor Chetan Parmer, and Professor Javed Raza from Cleveland Clinic, Abu Dhabi. So how we will go ahead? What is our overall, how can we go ahead? So we have 3 sessions, 3 questions main. First is patient selection. Second is about some technical point, if they want to highlight one of them. And third one, that is the most important, is the results of their technique. So I will request, so definite same, then this will be about 1 hour. Then we will go for next session. That is also about metabolic surgery and ileal interposition and jejunal-ileal bypass. Professor Alpercherek, Professor Surindra Ogale, and Aaron Tashkin will be panelists, and moderators will be Professor Nathal Zandal, Lauren Layani, Kirman Saravi, Sonja, and Tansir Asghar. And at the end, so we will talk about this MGB and Roanwai. Someone they are also doing MGB and Roanwai in low BMI with adjusting BP limb. Also they have, and we have Professor VG, Professor Lee, Professor Virubirio, Professor Kareem Sabri, Professor Michael Karner, and Padma Kumar. And same we will have Professor Amir Khan, who also chair all of this session, and also Professor Bruno Deleman, Atif Inam Shami, and Chetan Parmar. My expectation from Chetan in all of these sessions, at the end, we will give him some time to talk about data, because he's as well as a scholar of, as well as surgeon. And when Chetan will join us, so we will request him at the end, so talk about something. So what is the data about this session? So I will invite Professor Asim Shabbir. Sir, over to you, and please start your session, Sleep Plus. You can start with any panelist, and you can start pre-op or patient selection.
Thank you very much. A very good evening, good morning, good afternoon to everybody. Thank you, Imran Abbas, for the kind invitation, and to our good friend Amir for the great, Professor Amir for the great talk just earlier. So we shall begin the session. Welcome to all the expert panelists. So we have a set of questions that we will just run through. And I think the best way of doing this at this point in time is to ask everybody, since we can have a consensus and we need to tag this up within an hour's time. So I would like to begin with the first question, which is, how would you define low BMI? We'll just go around the table. We have 7 experts, and if we agree, then we all agree on one statement. What's the lower limit of your BMI? Professor Santoro, is it all right if we start with you?
I don't think, hello, Asim. I don't think the Santoro is here. I can see
was in operation room. Yeah,
yes, I think he's stuck in an operation room, so he's not going to join.
Is the Professor Di Paolo here? Di Paola?
I don't think so as well.
Tariq Mehdi,
No.
Tariq is not here.
Antonio Torres,
Yes, professor is here.
Professor
Yes,
Antonio
I'm
Torres.
here.
Hi,
Yes, I'm
Good
Antonio.
here.
afternoon. Thank you for joining us on a Sunday.
Yeah, yeah.
What
The
do you
question
think?
regarding, yeah, you know,
In
this is a very
your opinion,
controversial.
what do you think is the lowest BMI that should be? What would you consider low?
I think, you know, you have to fix or to go close following the, you know, the consensus that you already have with the within Ipsos SMBS, the new paper regarding that. You know, I think, you know, I think 30 now is going to be the lower range for indicating surgery in the case of patient. BMI of 30 with comorbidity going to we have to fix or to follow the international rule. I don't think we can consider with the one of the decrease regarding the Asian population. You have, you know, to go down the 3 or 4 points. But I don't think, you know, we must have any unit have a, you know, a personal lower BMI index. I think we have to follow the international advices and rules and consensus. I think, you know, following the last one, I would say, for me, BMI of 30 plus comorbidities, with the exception of the ASEAN population, is going to be lower 2 or 3 points of BMI as the new, agreement regarding the new indication about, you know, the bariatric and metabolic surgery. I don't think we must follow, depending on the surgeon, this, you know, this level or this range.
Thank you, Professor Antonio Torres. So you agree with me that we will use the ASMBS SO guidelines, dropping it down to 30, the latest position statement that has come out, and that would equate to 27.5 for the Asian population.
For the Asian population, I completely agree, you know, because on the other hand, we will be crazy, you know, following different approaches and personal approaches. I think we have to follow the rules, the indication, and the agreement and the consensus that our international society are getting on.
Thank you very much. Dr. Kasama, would you agree with that?
Asim, I don't think Professor Kasama.
Professor C.K. Huang, are you there? Sorry.
You can hear me?
Yeah.
Yes, Professor
Okay.
C.K., we can hear you.
Good night, everyone. I think Antonio is talking about the guidelines. So for Asia Pacific, we use the BMI 27.5. It's the lowest BMI. In Taiwan Society also published a white paper about 4 years ago. It also mentioned the lowest criteria is BMI 27. With HbA1c more than 7.5, poor control, you can consider metabolic surgery. But look into the real practice. For those BMI 24 to 27, if the patient have high body fat percentage with preserved the beta cell functions, if the patient is eligible for the surgery, we still proceed to do the surgery for this kind of patient. But look into the guideline. I think the BMI 27.5 is the best to prevent some errors for those who surgeon want to get into this field. So stick to the guidelines, still important.
Thank you. So we have a consensus here. Is Professor Carlos there then? Well, thank you.
Hi.
Thank you. Yeah, Professor Carlos, would you agree with what has been stated thus far?
Yes, perfect. I'm listening some redundant sound.
Sir, we can hear
Are
you.
do you hear me?
Yeah.
Yes, I can.
Okay. Well, there is a misconception. If you go back in the early stages of bariatric, we consider low BMI between, people from West, between 35 to 40. Now between 30 to 35. And maybe in the near future, we are considering even below. And this might happen also with the Asian population. So this time, I consider below 35.
Thank you very much. Thank you for that insight. So what I hear is we have a general consensus, 27.5 and above being the indications for bariatric metabolic surgery, for at least as far as low BMI is concerned with comorbidities. And it was interesting, Professor C.K. Huang just mentioned just now that he would consider some those are low BMI with different, even further lower BMIs with different composition of body fat as indication for surgery. So may I ask Professor C.K. Huang, then in diabetic patients, is this only for diabetic patients that you would bend this criteria and bring it lower if they don't have good control of comorbidities, or would you make it a more generalized criteria? Do you have any other for diabetic patients?
I think right now, mostly surgeons will agree that metabolic surgery mainly is working on the diabetes patients. The reason is diabetes cause more cardiovascular complication and long-term the other organs dysfunction. So those who have only hypertension or only hyperlipidemia is not my consideration. So for those who qualifies as a metabolic surgery, mostly we thought only diabetes is the main reason we do the surgery for them.
So would you even offer this surgery to those who have who on medications are euglycemic and low BMI?
I think that to say is euglycemic or related good control with medication, mostly I give the option to the patient that if he want to quit this medication, or if he has been a few years, more medication was used, since from the single agent to 3 agents, or use insulin right now to keep on the better condition of his control, then I will consider surgery for him, because it means the patient's beta cell function is dropping. So that is the reason that I offer the surgery to the patient with relative good control.
Thank you.
A question for CK. That's a very valid point. Hello, CK. Good to see you.
Yes, Keaton.
So I agree for diabetic and low BMI with high, when you said diabetes is uncontrolled or on insulin and stuff. Do you use simultaneously also any scoring system like, ABCD or diagram or something to kind of justify or talk to the patient?
Okay, I think to use these scores most is the possibility of the remission to explain to the patient. We use this to talk with the patient, but in fact, I think the full remission or partial remission or improvement in diabetes control is all important. So whether the patient is in good scores means that patient has better remission possibility, then we just offer the surgery to this patient. I don't think so. Our goals is the surgeon or the diabetologist always mainly on the better control for the patient. So for those who have preserved beta cell function, still have high body fat percentage, it means the patient have insulin resistance but preserve beta cell functions. When we talk with the patient willing to receive the surgery, I still will offer the surgery to the patient. But the main goal, whether it's really full remission or not, or just to make the patient have better improvement or control for the disease, I think that is the between the balance of you and the patient.
Thank you.
CK, I've got a quick question. Would you, and the question is directed to CK, this group of patients, would you operate in your regular clinical practice or in an IRB or research or study setting? These lower than 27.5.
Okay, BMI 24 to 27 mostly will meet the criteria of the IRB. And those BMI more than 27.5, mostly we don't use the IRB for the patient anymore.
So they are in the setting of.
Thank you. I think
research.
that's important to clarify.
Yeah. Thanks. So we go to Professor Antonio Torres. Professor Antonio Torres, would you investigate these patients with lower BMI any differently than you do the normal cohort?
Sorry. Let me, no, really, you know, I don't look for any other pattern. I mean, you know, the patient is a patient with type 2 diabetes. You know, we have the, you know, the criteria or the you know, the universal criteria for that. You know, of course, we are taking care of the age of the patient and the global metabolic status of the patient, but not any special, you know, situation. Now, of course, it's going to be important how those comorbidities, including type 2 diabetes, but also dyslipidemia and also hypertension, have to be controlled before making the decision operating on the patient.
Do you look for LADA anyway?
Yeah, LADA, of course. Yeah, LADA, no. It's to discharge, you know, the patient has a real type 2 diabetes, of course. You know, you have to be sure that the patient is type 2 diabetes. Of course, you have to, you know, discard or, you know, to rule out other causes of diabetes, for sure. But we include it in low BMI patient, we include in every patient. And in those patients, even with higher BMI, you have some doubt regarding that, we do the LADA test.
So do you in your routine practice use any calculators? Because most of the calculators that are available, look at, you know, they are designed for the 37.5 and above BMI, looking at data from Cleveland Clinic and the Durham, some of them Asian patients. Do you think these calculators are really representative of Asian data going down to 27.5 now?
Yeah, you know, in our clinical practice, we have so many patients over 35, over 30. They're going to be very exceptional, you know, to face with this kind of patient lower than 30. You know, it's a different population you have in the Asian area. You know, it's completely different. Here in Spain, we have very heavy patient with a hip problem. Sometimes in a very punctual way, we have a look to the Cleveland Clinic score in terms of getting some, you know, orientation, but we don't really use in a practical way in a clinical practice in our day after day practice.
Thank you. Professor Carlos, over to you. Do you agree with what Professor Antonio Torres just said? Would you investigate patients the same way? And do you use any calculators? Same question to you.
Well, thank you. Do you hear me? I changed
Yes,
the
we can hear
microphone.
you.
Yeah, we can hear you, Carl.
Oh, sorry about that. Okay, sorry about that. Yes, I do exactly the same approach below and over 35. Okay. Yeah, even patient with LADA, when they are obese, severely obese, they have remission for like 10 years, and it improves their quality of life, and also they can avoid many complications with diabetes. So it's important to evaluate that, to assess if is LADA present, only to advise patients that they might have diabetes or diabetes relapse. But I do exactly the same.
Lovely. Thank you very much. To you for the next segment, if that's all right with you.
I had a quick question here for this panel. You know, we all talked of operating on these patients with diabetic. So question to Antonio, CK, Carlos, everyone. HbA1c, obviously we talk of that. Now, if a patient has HbA1c of 10, do you think the patient is safe to proceed? Because off and on, this debate keeps on coming, saying, oh no, they are high risk, they need to be controlled, send them to a diabetologist, and they have to try and control it again. So what is your cutoff? And if not, how do you justify? So let us say 7 is a cutoff theoretically if you in your practice, but if let us say somebody with 9 or 9.5 is not able to be controlled, how do you justify or how do you triage or prepare that patient?
The question is addressed to whom?
Well, Carlos, you can start and then CK.
Chetan, nice to see you. When the patient has a high A1C, I try to go down. Sometimes we can succeed them even below 7, and sometimes we don't. And I explain to the patient that we maybe the surgery won't be as good as we want, and sometimes not because H1C is hit enough. And I proceed with surgery, but the results are not as good as when we can bring it below.
CK,
and the cutoff, the ideal cutoff is
I think we lost Carlos's voice. CK, do you do similar for control?
I think those coming for metabolic surgery, their HbA1c or more than 7, fully controlled. Our patients' average HbA1c before surgery is about 8.6. So I don't control the patients to HbA1c less than 7, then we do surgery. But I admit the patient 1 or 2 days before the surgery to control the sugars about 150 to 200 range under the insulin injection. So after that, the patient was hydrated, give the enough control of sugars, then we go for surgery.
Can I add something?
Yes.
There's a very famous study named the UK PDS trial, which was done in United Kingdom, and this study has shown that any HbA1c above 6.5 damages your organs. So the cutoff should be 6.5. The UK PDS study has shown that if HbA1c rises from 6.5 to 7, then organ damage rises by 8%. So the cutoff should be 6.5. This is what the big study has shown us.
And agree. Thank you.
So, Chetan, what is your personal take on it? And I'll share my personal take and practices on it.
Well, I was hoping all the expert panels to answer this rather than me. But yes, I think I agree. We all aim to control it before, you know, in your preoperative assessment before listing them for bariatric surgery. But there will be an odd 1 or 2 patients whose HbA1c is poorly controlled, who are playing around 9 or so, or even maybe 10. I think we counsel them accordingly, get them assessed. I get them assessed by a high-risk anesthetic expert. We have a separate anesthetic consultant and a diabetologist looking at those cohort of patients, and then ideally admit them a day before. But yes, that doesn't mean we cancel their operation, but we try our best to control it and then have it in a planned way. But do
Asim,
Yes,
may I just
Javed.
add a comment?
Please do.
Would it not be important to notice what the change of HbA1c was during preparation? If someone has come from 12 to 8, that is a significant change from someone who's come from 8 to 7. It does indicate a shift. So I think it's not just the absolute number, but the change from the previous point to the current point, and perhaps that we should consider as well.
Completely agree, and a valid point. I think that's why that preparation phase is important to monitor and seeing rather than rushing in with a surgery.
Sorry, this we can have a standardized data about this topic. Let me tell you about what we do in our clinical practice. When a patient comes to us with a poorly controlled diabetes, what we immediately do is a mixed meal tolerance test. This test includes 400 kilocalories of carbohydrate, fat, and protein mixture. And before the breakfast and 1 hour after the breakfast, we remove blood samples. What we analyze are three things. One is HOMA sensitivity. The second one is HOMA beta. And the third one is quantitative insulin sensitivity check index. HOMA insulin resistance, HOMA IR, is not a good indicator in low BMI people. I will explain you the details of why we shouldn't trust to HOMA insulin resistance in these people, but rather, especially quantitative insulin sensitivity check index is the main denominator of success in these people. So what we do for the last 15 years is a mixed meal tolerance test immediately after these people reach to our clinic.
Thank you. So I think, Chetan, what we have a consensus is here is that one, we all agree that we need to basically manage this patient, try and improve his glycemic control as much as we can, optimize before surgery. That's one. We should investigate whether this is just due to the patient's reasoning of not taking medicines, compliance reasons, or truly is this like a beta cell failure where we are reaching towards the end of disease process, which is giving him the hyperglycemia or her the hyperglycemia. So it seems to be there. Most would agree that data, I think the data stands at about 10 HbA1c, beyond which the risk of anesthetic complication increases. Below 10, the anesthetic complications, if patients are well hydrated, remain reasonable, and you can continue. And as Dr. Javed just educated us, it's probably the delta between the initial presentation that even counts a bit more towards it. Thanks, Chetan. Do you want to carry on?
Sir, I think Professor Tariq Mehdi is also with us.
Oh, okay, great.
Professor
Tariq, do you have any comments, please?
Yes, he has joined here. He's here.
Yes.
Patient selection, sir.
Good evening.
Sir, please, you can share your experience about patient selection for metabolic surgery in low BMI, especially now we are talking about HbA1c and as well as BMI. So what is your criteria?
Yeah, good evening. I think HbA1c usually it is a history of patient for the last 3 months. So for any operation, you must be HbA1c less than 8. But usually we try to control the blood sugar in the 2 weeks. Then after that, we decide to do operation. As regards the low body mass index, usually we have here in the Gulf with body mass index between 30 and 35, and also with the patient of diabetes, and also patient is failed with other regimen for diet or have balloon before or Botox, and the patient failed regimen for more than 3 months. This is our criteria for low body mass index to proceed for operation. You hear me?
Yeah, sir.
Yeah,
thank you, sir. So because we must go ahead, and I request from Professor Javed, so we can little talk about the results, because we know, so this in this group, this is a sleeve plus, so they are doing sleeve plus SASI, or Saj or Sadi. So Professor Javed, we can continue our session. So we can talk about their results and what's their post-op results. So you can start this session, sir.
Thank you. So if I may go back to Professor Torres, could you briefly tell us the outcomes of this lower for you is 30 to 35. What is the summary of the outcomes of results, metabolic results for these patients, and your procedure of choice for that?
Thank you. Again, I'd like to comment that we have very few patients here in our experience with BMI between 30 and 35. We already start performing metabolic surgery for 35 above with comorbidities. We have some very few patients in our experience with BMI between 30 and 35. Because we followed, the international guideline. We are not allowed to operate in our country, patients within below 30, very exceptional cases. Our endocrinologist, our multidisciplinary, we are stick to our international bylaw. We have very few patients with BMI between 30 and 35. I must say that in those patients that we perform studies, in those patients, the patients are doing very well. In those cases, we perform studies with a common channel of 300 centimeters from the urocecal valve. But it's going to be our experience. Now, with the new guidelines, starting with the 30 BMI plus comorbidity, we will include more patients. But in those cases, we will go upwards in the sense of increasing the length of the wall common channel.
Thank you. CK, what is the summary of your outcomes and any change in the technique of your operation for these patients?
Low BMI diabetes patient, mostly we would do sleep with duodenal jejunal bypass is our preferred operation. Mostly we live about the common limb is 3.5 meters. We cut the stomach to be more smaller, so we use French 38 as a gastric tube. So in our series, you would look at in low BMI cases, the BMI 30 to 35, the result is better than the BMI 27.5 to 30, because the lower BMI, if the BMI lower, then the beta cell function mostly is still worse. So to consider doing the surgery in this low BMI, you still need to look into the reason of the patient's diabetes. And so eventually from the BMI 27.5 to 35, this group patients, the diabetes remission rate with the duodenal jejunal bypass is about 70% for the full remission plus the partial remission. Okay.
So if I understood it correctly, the lowest BMI ones are not producing the same amount of results from metabolic point of view as slightly higher BMIs. Is that correct?
Yes, yes, yes. So as you look at into those grading systems, the score systems, the BMI is one of the point. It is. So when the BMI coming lower, then the patient can have less chance to get remission.
Let me comment something, on that, regarding. May I have a comment?
Yeah, please, sir.
Yes, please. Yeah.
Okay, please, because pointing out that supporting Dr. Wan, comment. Remember the clinical trial that Professor Scopinaro made some years ago in a patient with BMI between 25 and 30, published in New England Journal of Medicine. He performed clinical trial doing a standard BPD, a Scopinaro procedure. So he said the same. When the patient has a lower BMI, the result of metabolic surgery is different, because the type 2 diabetes in those patients is a different disease, guys. I think the results are going to be poorer than that we have with the lower BMI, with the higher BMI. I got to support the third one comment. It's very important to consider. Don't apply very huge numbers of patients with a lower BMI, because metabolic surgery result is going to be poorer than the other patients.
Thank you very much. I note we have got Professor Vigili as well online. Professor Vigili. Hello, welcome. Could you share your experience in this low group, any change in your technique and the outcomes that you noticed in the lower range of the BMIs?
And I think if patients really have serious diabetes and come for diabetes treatment, I didn't change a lot on my technique because the primary aim is for diabetes remission. So we can accept the side effect of the OAGB of my procedure, yes.
So your procedure of choice would be OAGB and the limb length would be
150.
The same. I pass as long as possible to make sure I have enough common channel. And one beauty of OAGB is it's a reversible procedure. So when you come into low BMI, you will feel more comfortable because if anything happens, you can just convert back, especially when at the initial period, we don't know much about the metabolic surgery. So I think it's much safer to do this procedure for me.
Thank you. And did you notice any difference in the outcome in the lower 27 to 35 BMI range compared to the higher BMI?
No.
Sure. The low BMI, we really expect a lower remission rate, as CK has mentioned. Yes, because in this group of patients, they always tend to have a low beta cell. So I deeply rely on my ABCD score. I think it's more convenient to talk with the patient what they can expect. If their score is really bad, I will advise them not to do the operation. Yes.
Thank you. That's great.
Sir, we can take this opportunity. If possible, Professor Lee, please share that score. Maybe it will be.
I think it's quite easy. Age 40, you have got one point, and BMI, you need to at least 27 to get 1 point. And for a duration, you need less than 8 years. Otherwise, you get no point. C-peptide, you need to have a 50% of the upper limit according to your laboratory data. So if you don't have any point in this 4 category, I don't see why we can do operation for the people. But if they have 2 points, you can much easier to do the operation because you can expect a 50% remission rate. Yes.
Prof, does this scoring system? Sorry, if I may have a question to Prof. Vijay since he's here. Does this equally apply to patients with low BMI? Your data for the
this is especially for low BMI because in high BMI we really don't care about much. BMI more than 35, no matter what is the score, we can do the operation. But in low BMI, we really need more information to know what we are doing and to talk with the patient. So I think it's more important when we're doing low BMI. You really need to have some score so you can expect the real outcome before you're doing the surgery. Yes.
Thank you.
This is my thought.
I just have a comment, if possible.
Okay, I'll go on.
Yes, sir.
We have previously published our data, I think it was 6 or 7 years ago, comparing BMI 25 to 30, 30 to 35, and above 35. Okay, these 3 groups. And as can be anticipated, we were expecting for a mathematical correlation with the better success rate with the increasing BMI, but it didn't happen. The highest rate of success was in patients with BMI in between 30 to 35. It was even higher than patients with BMI above 35. So we shouldn't be expecting for a direct mathematical formulation or correlation with the increasing BMI. My suggestion is looking for the reasons to understand which patient is an unhealthy normal weight individual. This is a very important point which we have been discussing with our colleagues. What is an unhealthy normal weight or overweight individual? And there are 2 main reasons for that. And I'm going to explain you in detail the reasons for which patient is a normal weight or simply overweight but unhealthy individual.
Professor Alper, I'm really sorry to interrupt, but what you're describing is fascinating, but I would request that we stay within our current limited time topic. Yes, thank you very much. Imran, I would suggest that
Sir, my humble request, because now in this session we have only 7 minutes. I will request to Professor Chetan Parmar, because in this session we were talking about SASI and SADI in low BMI diabetic patient. So what is the result of data, Chetan? What is we are interested to hear from your side, especially about SASI and SADI, initial SADI for diabetic patients.
Thank you very much. I mean, to be honest, you have here the inventors of SASI and SADI both here. So it's a bit unfair for me to highlight those, but I do remember reading recent papers. The good thing what we now have is that before this operation studies and SADI operated only in 1 or 2 units, and the popularity has increased now. You have more and more multi-center studies. So if you look at, I think Antonio group, and I can see Rui here as well, and Laura and a few other people who do SADI-S, and there was a multi-center published with the SADI-S, which has shown very promising results, and it has also shown good results with the diabetic control as well. And even in, there is no separate, as far as I remember, there is no separate low BMI group paper. I think there is a paper with a high BMI group, but not with low BMI. Is that correct, Professor Torres?
Yes, yeah, you're right. But the problem, you know, is the way we can consider the surgical techniques. I think, you know, the duodenal jejunostomy, you can consider a proximal studies. It's the same, you know, the concept is the same. The only thing is the length of the common channel. So if you increase the length of the common channel until performing a duodenal jejunostomy, for me, I think this kind of duodenal jejunostomy, is going to be the ideal procedure for the low BMI patient with metabolic problems. As you know, the Taiwanese, the third one is here, you know, and all the Japanese people, Kasama is also here, I hope so, and you know, you can confirm my words. I think, you know, if you consider the duodenal one anastomosis procedure, I mean, with a sleeve procedure, a sleeve plus procedure, you consider the duodenal jejunostomy, depending the length of the biliary limb, and counting on the common channel, you know, it's a proximal studies. If you consider this kind of operation really widely considered as studies, you know, the proximal studies or duodenal jejunostomy, in my opinion, going to be the ideal procedure for low BMI patient with metabolic problem, including type 2 diabetes mellitus, because we have enough experience on that.
I disagree.
Thank you very much. And similar coming to SASI now, Imran, you were mentioning, for SASI as well, initially we had papers from Professor Mahdi, but I remember, I think was it last year, year before, there was a multi-center study now, a combination of patients from different countries, including Portugal, Germany, Norway, Middle East. And I think I can see a couple of co-authors here, Professor Mahdi, Rui, where they found excellent results with SASI as well. And as far as, again, I remember, they don't have a separate cohort, because I think the mean BMI in that patient group in that paper was around 40 to 42, but not a separate paper looking in low BMI diabetics, what we are talking of, say 27 and less than 30. Is that correct, Rui? I think I can see Rui and Professor Mahdi. Is that correct?
Yes, it is, in my opinion. Professor Akhtar has powered the study, multi-center study, studying exactly the the success of remission in diabetic people, type 2 diabetic people with SASI, and the outcomes were good, as you know, and I suppose that rate of remission was about 70% or something like that, but not in low BMI. What I can say is that in low BMI, I am in the same situation, Professor Torres. We have just a few patients with a BMI even between 30 and 25, and so we don't have so many patients. Anyway, I'm following very closely my series of the SASIs or OATBs, as I prefer to call it, one small transit bipartition, and also my transit bipartition classical ones series. And I have some patients, and I can see that is very effective, and the remission rate is for sure about above 80%. And I should say also that previously I was performing OAGB in that situation, but with SASI or OATB, the outcomes are the same or better even in this setup, the set of patients with BMI between 30 and 35. I don't perform below 30, but the outcomes are very good indeed. And we have the advantage of not having by now duodenal and jejunal exclusion. And of course, even if I think that in very serious or very healed patients, we need to go further for duodenal, jejunal, or ileal anastomosis.
Sir, so much thanks, Chetan. I think this is going to finish, but just my humble request to Professor Tariq Mehdi, if he has any comment about his data or results of SASI in low BMI diabetic patient. Sir Tariq Mehdi.
Yes, thank you, Omar. I think when we are going to discuss the results for SASI bypass, there's no difference between low and high BMI. The problem almost always correlate with, for our patient, with C-peptide. There is a good correlation between if you have C-peptide more than 3 and the result of SASI bypass in low BMI and high BMI. So the only correlation with the result, because SASI bypass is good or powerful operation as the uterine switch for remission of diabetes. We don't change our regimen as regards the 3 meter from the ileocecal valve as regards low BMI or high BMI. We can offer our patient according to the C-peptide. Also, we don't have a good or bad results with how many years of diabetes, less than 10 years or more than 10 years old, not 5 years. But the problem almost always we offer good successful remission of diabetes for our patient, more than 3 C-peptide, 1 to 3 around 70%, or less one. This one is almost always around 25%. This is our result from SASI for low BMI or high BMI. We don't have any relation between body mass index and the resolution of diabetes with SASI bypass.
Sir, so much thanks. And in this session,
Imran,
Sir.
Imran, allow me to just put one comment before we move on to the next session. So what I think we have got giants of bariatric surgery in this session, and these are extremely experienced surgeons, but a lot of young surgeons are listening to this broadcast. And what I've understood is that there is not a high volume consistent data proving the efficacy of these procedures in lower BMIs. And if a complication happens in this group by one of the junior surgeons, then it would be very difficult to justify the existence of that complication in this lower BMI range group. So this is a word of caution and advice that I've understood. I hope I've not misunderstood the facts. Asim?
Thanks, Dr. Javed. Yes, I would totally agree. It seems from the experts here that the outcome data is rather scarce, and not only of clinical outcomes, but also of complications itself. So, and as we've heard in general, the outcomes of patients in lower BMI seems to be a bit more convoluted and complex in nature because of the nature of disease, especially diabetes. The outcomes are also impacted. So A word of caution for those who go below the ascribed values of 27.5, it should be done still under IRBs, and data should be collected to fortify the existing data. Thank you.
Thank you,
And
Imran.
on that note, I just wanted to put another point that, you know, some people, even all these experts are doing these operations in low BMI. I would always encourage people to publish those things so that we have that, because I'm sure people here would have their own cohorts of even 50 patients or so. So even if we start putting those small numbers now out, in 5 years, 10 years, then we will have a sum up of a larger number, and then we would not then worry about published data. Then we have proof out there as well. So please publish whatever data we have, even on this low BMI.
Sir.
Yeah, I think it's been a very interesting discussion. To be honest, I think we're a bit overrunning because we're going to move to the next session soon, as Imran said. But I think the cautionary note which was put on by Javed is very important. And I would still emphasize that this group, we need to do it in studies, controlled studies, rather than trying to have a carte blanche and everyone starts doing it, because I think that's where we're going to create problems. Because so far the data, the BMIs we've had have come through a lot of research and studies. And I think we ought to stick to that as a general rule. But if we want to challenge and go and challenge the boundaries and go into more new avenues, I think one ought to do that under controlled studies and try to publish the data as it's been suggested. Great. Thank you very much. I think with this, we're going to close the first session. We need to move on to the next session. Do you want to have a quick break for water adjustment of your fluid balance, or can we move on to the second session?
Sir, we must go ahead.
Okay. Imran, do you want to introduce, and let's move on to the second session, please?
Sure, sir. Definitely, because we have divided these sessions on the base of interview. And in this session, we will have as a panelist, Professor Surendra Ogale, who is pioneer of ileal interposition, Professor Alper Chilek, as well as he's also one of the pioneer, and Aaron Tashkin, because as I interview these legends, what was my analysis, their patient selection, their definition of low BMI is totally different. And we are interested to hear from your side. In this session, our moderators will be Professor Laurent Layani, Professor Nathan Zandal. This time, Professor Nathan Zandal is inside the aeroplane. Just they are going to land and he will join us little late. Professor Kirman Saravi, Professor Sonja also, she sent me message just now. Maybe she will join little late. And Professor Tansir Asghar. I request to Professor Laurent Layani to start this session with Professor Surendra Ogale and continue. We will start with patient selection, how this group they select a patient for metabolic surgery. Professor Laurent Layani.
I'm sorry, I just lost the screen. Just give me 1 second. 1 second. I don't know
No
what
issue,
I've
sir.
done.
No issue, sir.
I was perfect and suddenly.
Yeah. Sir.
Yeah.
Sir, we have in this session, we have panelist Professor Surendra Ogale, he's live with us. Professor Alper Chilek, he's live with us. And Aaron Tashkin, he's live with us. So their technique is totally different. And also their patient selection is also different, because I interview all of these legendary surgeons. Just you can start with Professor Surendra Ogale about patient selection. Please, sir. You can invite and you can continue. Sir, Laurent, can you hear me?
Yes, I can, but I cannot see anybody, so it's okay. So I first of all, I would like to congratulate you for this wonderful. Can you see me?
Yeah, we can see, sir. We can see hands.
Yeah, I would like to congratulate you for this wonderful meeting. I just want to make a very short comment. I didn't want to speak before my session on Jared's comment from
from Abu Dhabi. And I think he's right. I think the most important is, I mean, I do very rarely, but I do patients sometimes from 27, 26 BMI. You know, in UAE, it's not a very common operation. They are mainly referred by the endocrinologist. And the key of this, and I respect Jared's comment, and is why I just want to say that it is important when you do any kind of operation in this kind of patient, I believe that you need to offer the patient the less risky operation, and perhaps the one which you can reverse. So I with all my respect for Professor Antonio Torres, I don't believe this group of patients should be operated with a SADI. Perhaps with the technique of the Taiwanese guys, but certainly not on a SADI. You need to have an operation which is safe and low risk. In regard to these second sessions, which you put me to moderate, Suren Gali is a very good friend of mine. He's a king of the ILO interposition with the South American guy. I watch him and assist these guys to do this operation once in India, which is the horrendous operation. I am not really the best person to comment on this, and so I'm going to let these other guys to start and comment. Hello?
Imran has gone a bit silent at present.
So, one second. I wish I could see everybody. It's
hello, Lauren. I think you can start with putting the questions onto the panelists.
But I cannot see the panel. I was seeing the panel before, and for some reason,
Sir, Surendra is live with us. You can ask the question. They are live with us.
Laura. Hello, Laura. I'm here with you.
You saved me, because it's very hard for me to talk about something. You know, I like talking, but not about something I don't know. And you are the man. So, it is true. It is true. I mean, you have to be, when you get older, you just, you are a little bit, you know, we get a little better. You have to be humble, right?
Yes. So,
I mean, the question I think the audience would like to know. I have discussed with you so many times in India and in many places around the world. What is your indication for, and the BMI related to your indication for allele transposition in your practice, which I have visited in Hyderabad some times back? Tell the guys.
Well, thanks for having us. It's a pleasure being a part of this phenomenal lower BMI metabolic surgery sessions. And this is where a lot of our work is focused on. And Laura, I'm sorry if you can't see all of us. We can see you clearly.
I will find out. Don't worry. Don't worry.
But we can
just
see
carry
you clearly.
on. Carry on.
Can hear you clearly.
Carry on.
And just to set things right, when you mentioned about king of metabolic surgery, I would say Oreo De Paula is the king of metabolic surgery.
And you.
who has taught all of us so much about metabolic surgery, the understanding, the pathophysiology, and so much of science which goes into this. It's unfortunate we don't have him with us. I think maybe Imran can say whether he's going to come on or not. But to go back to what you asked me, so the focus when we are dealing with diabetes, now the important thing to realize is these are not patients primarily of morbid obesity with diabetes, where the diabetes could be mild. These are patients with diabetes. And now when we talk of the low BMI group, there is a clinical obesity because of the body fat percentage, but in BMI terms, there is no obesity. So our focus is on diabetes, and so our patients range from BMI of 21 and above. So we don't look at BMI. We choose the patients that really are suffering from diabetes, poorly controlled, or they might be well controlled, but with a lot of medication, with or without insulin. We definitely need to make sure they don't have any autoimmune, component like LADA. So when we take a clinical history, if you find a patient who for 5 years has been on oral hypoglycemic agents and they are reasonably under control, you can be sure this is a type 2. If within 5 years you find that the control has slipped and they are already going onto insulin, you definitely have to do the antibody checks to make sure they are not LADA. Because if they are, then we're going to exclude these patients because you won't see any result in them. Then we focus on patients who have some complications that may be in the milder ranges. There's early nephropathy, early retinopathy, because these are patients and these are the conditions we can reverse after doing ileal interposition. And any patient where there's a very strong family history of complications due to diabetes, or the drugs are going on increasing every 2 or 3 years, and the drugs are increasing and the control is slipping, these are the patients also we would accept for metabolic surgery.
Sir, Alper, we are interested to hear from your side, please. Patient selection.
Well, you don't have much to say after Dr. Ugale. He's my mentor, and he has ever been a humble person. I do appreciate him. I have added a little bit to what he has taught me. And one of them is a very detailed patient selection. We do not only do the mixed meal tolerance test in patients who are applying to us. In addition to that, we evaluate the plasma-free insulin levels. This is an important point because when you go into the field of low BMI patients, you need to have a good emphasis, a good understanding of the pharmacologic treatment of diabetes. And we have 3 main problems in these people. Let me categorize it into 3. Number 1 is a glucotoxic and hypoinsulinemic type 2 low BMI patients. We keep away, okay? Number 2, glucotoxic and hyperinsulinemic people, okay? These people have a big chance. And number 3 is glucotoxic and normoinsulinemic people, okay? Taking back to the pharmacology is three new onset insulin medication, which are Toujeo, Ryzodec, and Abazaglar. These 3 insulin types do not lead to a weight gain in people with low BMI. Okay, they don't gain weight. They are prescribed in supraphysiological doses. Okay, Ryzodec, Toujeo, and Abazaglar. They are supraphysiologic insulin analogs, and they are prescribed twice daily. So these people are hyperinsulinemic. Okay, you need to discriminate these low BMI patients with hyperinsulinemia. We take these patients into the hospital and we give them a liraglutide treatment of not less than 3 days. If these people make it possible to express a significant increase in their C-peptide levels, not insulin, a drop in insulin and an increase in C-peptide, yes, this patient is a good indicator, is a good candidate for surgery. Okay. And the third group was glucotoxic and normoinsulinemic, low BMI people. In this group of people, there are two reasons. Number one is gliflozin medication. It can be canagliflozin or dapagliflozin. Okay. Canagliflozin, and these are the SGLT2 inhibitors. Okay. So these SGLT2 inhibitors lead to a significant weight reduction, unintentional weight reduction in people with diabetes. So when you see a patient, normoinsulinemic glucotoxic patients, you need to consider, number one, cessation of the gliflozin treatment, and number two is smoking. Smoking leads to a very significant sarcopenic anatomy. Sarcopenic anatomy is you lose your muscles, but your fat is always there. Okay, so when you see these people, number one, stop cigarette. Number two, stop gliflozin. Okay, and de-evaluate these people 1 month later. Don't go immediately. These are the three tricks and to bring in mind when considering low BMI people.
We are with now Tansir Asghar and Kirman Saravi. Please, sir, as a moderator, you can continue, and also with Aaron Tashkin, especially for patient selection. Tansir, you are live with us.
Yeah, thank you, Dr. Imran.
Please.
Very interesting talk going on. I would like to ask Aaron, what are the lab tests compulsory for the metabolic surgery? And what does the period of diabetes that affect metabolic surgery?
Yeah, I think Dr. Charik and Surendra Bugale also give a very good explanation of how to select the patients according to their onset of diabetes and the medications they are using. But what we do routinely is we check also for C-peptide values, both fasting and postprandial. And also we only not look at the hemoglobin A1C levels and the blood sugar monitoring of these patients, but also we look at the quality of life, because I don't think that only the lab work can lead you into a way that you can operate these patients. Because in the past, we have some examples of these patients that we made jejunal anastomosis, or we did transit bipartitions or mini bypass. I don't do ileal interposition. I don't do diverted ileal interposition. But what we do in our clinic is we have done 50 patients with jejunal anastomosis. Even I did with Dr. Dilamas. He's not here. But we did these operations for the patients with low BMI. And what we see there, not only their blood work, how severe is their diabetes, or how much insulin they're using for how many years. I think there's a clock in every patient. Because like obesity, in diabetes, there's a big clock that is ticking away. Whatever you do for these patients, about 50% of your patients will be coming back with diabetes. Although you are thinking that you are doing the best, you are doing the best selections, you are doing the postprandial test, you are looking at the pancreas, you are doing everything, checking for every little detail in these patients, 50% will be coming back in 3-4 years with diabetes again. But what we see here, if you select your patients according to what they're eating, what they're doing, or they can change their behavior. Not only, I'm not talking about obese patients, but also with these lean patients. I think they will have more time, and you're going to make these patients heal for some amount of time. But you're not going to cure these patients. This is impossible. If you say that you're curing these patients, this is, I think, against science, because we know that you cannot cure diabetes, you cannot cure obesity. And maybe some of you will be angry. You're going to say that I'm curing these patients, but I want to ask about your follow-up rate, because when your follow-up rate is not above 70%, you cannot know that what you are doing with these patients. I think it's not a matter of like checking every detail, every value. Okay, we are going to check the C-peptide values. We are going to check at their hemoglobin A1C levels. We are going to look at their pancreatic reserves. we're going to do this test and that test. But when we see that these patients are not doing very well in the future, when you're not following up these patients, you cannot know exact. And when I look at the data, I see that there's no much data other than retrospective studies on this subject. That's all I want to say.
Aaron, what is your average follow-up of a patient? How much you follow up the patient? And can you just repeat what metabolic surgery do you prefer in low BMI patients?
Yes, our follow-up rate is about 60%. It's not about that.
Okay.
And what I offer for low BMI is mini bypass, where I take the limb about 120 centimeters, or sometimes 100
So it's a tailored bypass.
And
it's
yes,
tailored bypass, right?
bypass, and also jejunal anastomosis that we do, and also transit bipartition. I don't do the other surgeries. I'm not expert on that. I cannot comment on these. Sorry. But what I know.
What are the percentage of your patients who achieve this complete remission of diabetes?
Yeah.
What
Like
is the percentage?
transit bipartition, we have some publications, but we have the data more than 4 years now. And our average rate after 4 years is about 58%. But when we look at the preliminary results in 2 years, we see 74%. But the reason for we know that we can achieve better is that we don't follow up these patients. After 4 years, our follow-up rate drops to 37%. So we cannot say that the true remission rate is about like 58%. I think it will be lower if we see all the patients, like if we have a 90% follow-up. So I think follow-up is the most important thing.
I think Professor Kirman Sarabi is also live with us. Professor Mohammed, my request, so you can start technical points, because we are all interested more about ileal interposition, how these legends are doing this. Professor Mohammed, are you hearing me? Can you hear us?
Okay. Hello and
Now we
greetings
have
from
Professor
Tehran.
Surendra Ogale with us, Alper Chile. They are definite our leading person who are doing ileal interposition. So we can start with Professor Surendra Ogale. Professor Mohammed, please.
Hi, Professor Ogale. Nice to meet you. My question is, what is your preferred procedure in diabetic low BMI patients? Do you select ileal interposition in all patients?
Yes, that's right. We do the diverted or the duodenal ileal interposition in all these patients with diabetes. I'd just like to add something to the selection criteria. There's one important group of patients that we need to exclude, and that is when you do the fasting insulin and the C-peptide. If the fasting insulin is very low and the C-peptide is very low, less than 0.5, we definitely are not going to offer surgery, because this means that they've practically got a major beta cell burnout. When C-peptide is 0.5 and above, then we also look at the stimulated C-peptide. And if you see a good rise, then we take these patients. So that was just to add in the selection criteria.
Sir, technical points. So we are interested to hear from your side regarding ileal interposition. How you do this?
You mean the operative points?
Yeah, if it's possible.
So these being a low BMI group, we do a BMI adjusted sleeve gastrectomy. That's the first step, where we, in a person whose weight is normal and overweight range, we would remove mainly the fundus area and a little bit of the body. So we take the landmark as the crow's foot. When you are opposite the crow's foot on the greater curvature, you start over there for those who have BMIs that are in the moderate range, say, which are 30 to 35. We do a regular sleeve for the higher BMIs, and for the lower BMIs, which are less than say 30 BMI, we will start above the crow's foot.
and that is where the resection of the gastric volume is done. Now we will oversew the staple line, because this after we do a transection of the duodenum, then this gastroduodenal sleeve is taken retrocolic into the lower compartment. So we don't want to chance any bleeding or anything. That's why it is oversewn. So once the transection of the duodenum is done, then we create a opening in the retrocolic in the mesentery, bring this gastroduodenal sleeve down, and then start all the anastomoses which are in the lower compartment of the abdomen. Now there's one anastomosis which is a ilioileal, which is proximal to ileocecal valve at 30 centimeters. Another anastomosis will be then the uppermost one, which is a duodeno-ileal, where the proximal segment of the ileum is anastomosed. The distal segment of the ileum, that is then becomes a ileo-jejunal anastomosis, which is at 50 centimeters from where distal to the DJ flexure. Along with this, we also do a selective sympathectomy, which is based on all the research work which Aurelio De Paula has done. And this is to control glucagon levels, because otherwise we've only been looking at improving insulin, but we know that there is a sympathetic hyperactivity, glucagon goes up, and none of our procedures are bringing that under control. So to improve the results and the remission further, there is a sympathectomy of the hepatic nerves which are around the hepatic artery, and the nerves supplying the pancreas, which is at the base of the right crus, between the base of the right crus and the IVC, in that space. So this is how the ileal interposition, duodenal ileal interposition with BMI adjusted sleeve and selective sympathectomy is done.
Sir, can you show us a short video? Is it possible for us?
Okay, I'll pull it up in a short while. We can go on the discussion.
Mohammed, we can go ahead with Alper. So maybe technical.
Here, Alper, can you please define your technical aspect of your procedure, and tell me that what is your preferred procedure in low BMI patients with type 2 diabetes?
Well, yes, as Dr. Ugale indicated, the procedure of choice is diverted ileal interposition. Well, please keep in mind that ileal interposition has two types of operation. There are two versions. The non-diverted version, in which the duodenum is not diverted, is mainly carried out for people with an already existing colonic disease in non-diabetic, morbidly obese people. This is a very extreme operation in my point of view, and it can also be done in patients with transplanted kidneys and in patients with rheumatoid diseases, okay, because there is absolutely no malabsorption at all. The tips and tricks of diverted ileal interposition relies on the management of intracorporeal suturing skills, actually, in which Aurelio De Paula and Dr. Ugale are the pioneers in this field. You should see them both, like dancing with the needle in the abdominal cavity, actually. Number one is the mesenteric closure. Each mesenteric closure should be carried out with finishing the anastomosis. You finish number one and you close mesentery. You finish number two, you close the mesentery, and you finish number three and you close mesentery, one by one. There is no total mesenteric closure, okay? This will lead to a big confusion. And number two, which is the most difficult part of the surgery, is the duodenaileostomy. You do an end to side hand-sewn duodenaileostomy. The problem is, these people are already suffering from a significant atherosclerosis, and when you cut this right gastric artery, the tip of the duodenum turns into a bluish, a purplish color. And this brings in mind the question, is it going to work? Okay. We and Dr. Rugal have operated more than 12,000 people, and in total, we have 2 strictures, only 2, and both required a stenting. It works, but you should do a very meticulous hand-sewn end-to-side duodenaileostomy. This is the most difficult part of it.
Sir, amazing. So just I will take little opportunity. So this is a huge number, 12,000. So my request from both.
12,000?
In total, right? In 15 years.
12,000. This is a huge number. Really, we're interested to see personally.
You've done 12,000 of this?
Well, I don't know how many are diverted ileal interposition. We have done everything, by the way. We have done studies, we have done OAGBs, we have done...
No, but 12,000, Habibi, is little too much, right? I know what you're doing. I mean, come on, 12,000 hallual interposition. I remember I was talking with...
Not all interposition, mixture of surgeries.
I mean, it's a very big... But I can guarantee... Come on. It's a very big difference. Don't change. Let's talk about hallual interposition, because I spoke with a student, and even sometimes you used to do laparoscopic assisted open, which make a lot of sense, by the way, because it's so complicated. But with all my respect, I listen to you.
We have a 75-bed hospital in which 3 surgeons are operating at the same time.
No. Well, can I ask you a question then? My question I was going to ask you and Suren in regard to this. I've been talking with Suren for a long time, even when he come back from Australia. I'm talking about a long time, okay? Many years, over 10 or 15 years, in fact, we know each other. And why do you think, and I respect everything you do, I know you and you, no doubt. Why do you think this has not taken off?
Okay. Yeah, can I answer that?
Yes, please tell me.
So just to give you a sense, in our Indian Obesity Surgery Society, when I ask other surgeons that, aren't you even interested in learning ileal interposition? You don't have to do it. But what my experience was that once you got trained in this, you could actually do any procedure that you wanted to do in the bariatric space very safely, very nicely, very securely. And so I find that there is practically no interest, number one. Some of them have always said, oh, the surgeries take too long, and the same time I can do a few sleeves. So that's one attitude. Second, this is harder work for the surgeon, but I tell them that for the patient, for his or her lifetime, it would be hopefully a blessing. You would work hard on that day, but you are doing a procedure without any malabsorption for this patient and going to give them the best you can do in metabolic surgery. And when I ask them, if you have patients with significant amount of diabetes and medication and they're in the lower BMI group, then what procedure would you do? Because you're not allowed to do the bariatric procedures in that group. They say, oh, we send them back to the endocrinologist. What does the endocrinologist do? They add on more insulin and more insulin. So this is the real state of affairs. So I find that one is there is a certain inertia from the surgical fraternity. there is a reluctance because there are 3 transactions, 3 anastomoses, as Alpo pointed out, 3 mesenteric closures, etc., etc. And let me point out something else. At a time when BPD-DS was supposed to be giving the best results in the world, how many surgeons were doing BPD-DS in the world? 1.5% of the procedures were BPD-DS, 2%. What I find worldwide, majority of the surgeons want to stay away from the duodenum. Dissection of the duodenum, transaction of the duodenum, any anastomosis there. So you will find fewer surgeons in the world working around the duodenum, doing any operative area or anastomosis with the duodenum. And so that's why I think these are the different points in which it has not really taken off. And when you have fewer surgeons doing it, it doesn't get more and more popular. On the other hand, something like a OAGB, it takes off rapidly because now it is easier to do. It's only on the gastric side, easier to do the anastomosis, etc., etc. So I think majority of our surgeons look for easier options, not necessarily the best options.
Yes, but
Surendra, can I just come in? I think you've explained that very nicely, because I think it's a complexity of the procedure, which probably that's why most of the people are not getting onto it, because it's more complex. Did you manage to find the video just to share with us, because we only got another 20 minutes left for this session?
Yes, I have the video here. Can I share that?
Thanks. Thanks.
I love you, Sharon.
We all love Laurent.
Like, he's the best dancer in India. He's the king.
This is also part of life.
Yeah.
He's unbelievable.
So now you can share your screen
Sir,
with us,
just click
please.
share, then first, yeah, you know better, so how you share, but you can share. Because
He
you have
danced with
access.
the needle. He danced with the needle like he danced with the music.
We're going to get some dancing lessons afterwards. Let's
Yeah,
just end
you
this
should.
one. Laura.
You should, Baba. You should.
I'm just trying to find it on, I'm sorry. Okay, I think I'm going to find it quickly now.
Yeah, just you can click your video, then it will be on your desktop. Then you must click share. When you will share a screen, click. So then it, yes. Yes, now we can see your desktop. Then you can start your short video.
So can you see this?
Yeah.
Yes.
Okay, great. So what I have done here is, because the procedure is so big, now the sleeve is something everyone knows, oversewing everyone knows. I have taken up the part where the anastomoses are done. So let me start showing you this. It's a short clip. So this is, as I said, after doing the transactions, the first anastomosis is the distal one, which is the ileal anastomosis. And after the stapler firing, which is done with a 45mm white cartridge, we do the closure with 3-0 PDS. After doing that, this is to make the opening in the retrocolic mesentery and to bring down the gastroduodenal sleeve. So this is brought into the lower compartment, and then the duodenal-ileal anastomosis is a completely hands-on anastomosis, and this is the second one that's done. So first is an approximation of the transected duodenum, the staple line, with the proximal part of the ileal segment. It's an end-to side. And this is a technique, I must say, that I've learned this from Alper when we were both operating in Istanbul. And he's mentioned that he had picked it up from Kasama in Japan. And so I found this was better than what we used to do earlier. So once a sufficient opening is created, 3-0 PDS is a regular suture for all bowel anastomosis. And then it's a continuous inverting suture. So once you've got the edges approximated, you take the posterior layer to secure it further, and then you come onto the anterior aspect with inverting sutures. And after this, we do a leak test, because this is a proximal anastomosis, because remember, it's just the gastroduodenal sleeve. So since we can access this, we prefer to do a leak test always with anything that can be accessed. So you can, as Alper rightly said, a hand-sewn anastomosis we've always found felt much more secure than even a staple one, because the area being small, it's so much more difficult to manipulate a 30 millimeter cartridge to do a staple anastomosis. Sometimes you do get a wide area, and that may be okay. So this is the leak test, which is done with methylene blue, and that, yes, so that would complete the second anastomosis. And then we go to the third anastomosis, which is the ileo-jejunal anastomosis. Now, in this, I've not shown you the mesenteric closures. I should pull that up also to show you, but this was a nice short video. So this now is a similar side-to-side anastomosis. This is the distal end of the ileal segment. The ileal segment most times is 170 centimeters, as long as the total small bowel length is more than 550 centimeters. If it is shorter, then we make the ileal segment only 100 centimeters, because you don't want to take the whole ileum if it is shorter, proximal, and the jejunum after that. So it has to be only a part of the ileum. So this is a similar closure. So I think I'll stop this share so that we can go ahead with the discussion.
Yeah. Professor Kerman Saravi, Tansir, if you have any question, technical question from Professor Surendra Ogale, Professor Alper Chilik.
I got one comment, if possible.
Please, sir.
I have learned all these operations from the pioneers. I have learned TJB from Kasama. I learned BPD from Scopinaro himself, and interposition from Dr. Ugal and Dr. De Paula. And in the end, we were discussing that a method which is simpler in technique might be more feasible to spread among the world surgeons, okay? Because it was so complicated. Then I have met with Dr. Santor, and he taught me his technique, okay? And I have started doing transit by partitions in Turkey. And we have done thousands of it, okay? But after switching from diverted ileal interposition to transit by partition, although it's a much simpler operation, we have seen such severe complications we have never seen in interposition, okay? It is not related to the technique. It is not related to the complexity. The problem is you do all the anastomosis, in one compartment in ileal interposition. So there's no passage of any problem. But in a bipartition, when you take the ideal end to the stomach and you anastomose it, we have seen many complications regarding to the gastroileal anastomosis. So my final outcome is the complexity of an operation doesn't make it a bad operation. Okay, because the results are fascinating.
We know that.
Yeah, now I think we have 15 minutes now in this session, and we are interested to hear more about the results and your data, Professor Surendra.
Imran, can I interrupt you here? I have a short video showing the sympathectomy if you would be interested in looking at that.
Yeah. Just go ahead, because we talk about it a lot, and just show them.
Okay, so.
And this is a very interesting.
So this is the hepatic sympathectomy. So you can see this is the hepatic artery there in front. That's a lymph node.
Yeah.
Once the duodenal transaction is done and we divide the gastrohepatic ligament there, the duodenum flips over and it exposes this whole space. And you just make sure that
you do this before you bring the duodenum through the colon?
Yes,
that's
right.
You do before.
Yes.
After you do that, and then you do the colon through the duodenum through the transverse the window, right? Yeah,
that's right.
Yeah.
That's right.
Okay, I got it.
So here, of course, it's important you have the hepatic artery there. So important to make sure the energy source is away from the artery. So now you can see these nerves. These are the sympathetic nerves. You can actually see it on the hepatic.
On the fibers. Yes.
Yeah, you can see these white fibers. And
yes.
As Oreo has always pointed out, the more severe the diabetes, the more prominent you'll see these fibers.
Really? Do you mean they get bigger because of the diabetes?
Yeah, that's what he has said, that he's always seen that. And so that was the hepatic, and I'll show you the other, which is the pancreatic. So this is now at the base of the right crus, between the IVC and the right crus. So you can see the IVC on the left of the screen.
Yes.
And this
so
is
you opened the pars flaccida for that, right?
Yes, that's right.
Yeah. Okay. Got it.
And there you can see those nerve fibers now. So this is a delicate and a precision thing to be done, carefully. But Oreo has shown always that this gives an additional 10% remission rate. And so this is what we have been doing in all our patients ever since.
Yes, but how much you go from that? Do you go that and you stop, or you go all the way?
No, then this is stop. This is
only like that.
Only area. Like that. Yeah, just that small area. So all the
just
fibers
between the IVC and the right side of the right crus.
That's right. That's right.
Only okay. I got
Surendra, just amazing technique, man. It's and you wonder why not everyone does it, because it's scary. But one question here, once you divide those fibers, what do you think, do they regenerate and stuff? Because that's a natural tendency for, if you just divide it and things, would that be affected in long run? And does it affect your remission then? Or has anyone looked at it?
I don't think anybody's looked at it, but since there is enough of a separation, I don't think we get any early rejuvenation of those fibers. And yes, so the results have been
so right now
maybe in the long run, 4-5 years I was talking of, that do they regenerate in 4-5 years, and does that matter?
We have not looked at it really, so I don't think anybody
right now with your skill and your numbers, how long does it take? 3 hours, 4 hours?
I'm a slower surgeon. See, Alpa is a faster surgeon,
come
and
on, man.
Oreo is a very fast surgeon.
Time?
So, yeah. So my time is usually 5 hours or so.
Okay.
Sometimes we finish in 4.5 hours, but otherwise it's 5 hours.
And how many trocar do you put?
6 trocar cannulae. And just to add, I'm showing you one mesenteric closure over here. This was the anastomosis. That's the ileoileal anastomosis. And once that is completed, boy, oh, sorry, it's an anastomosis. I'm so sorry. I picked the wrong video.
They still look good.
Gap. No, let me show. Okay, so here's a mesenteric gap. It's a so the anastomosis is done. Ileoileal anastomosis is done. Now, when you pick up that end suture, you can see this gap over here.
Yeah.
So that's the base. So now you with 3,0 proline now, this has to be non-absorbable suture. And just to give an example, our good friend Professor Foskey in Milan, who also does this procedure, he always used to use Vicryl, and I suggested, Professor, why not use non-absorbable? He said, oh no, we don't have any problems. So I continued doing that. 6 months later, he met me at a complications meeting in Rome. He said, yeah, I got one hernia, so now I use proline. So
for sure.
appeal to all surgeons to follow the principles of surgery. So non-absorbable for all these mesenteric closures. One other thing as a feedback, I was presenting this in one of the SAGES meetings, and Phil Schauer, he got up and he said, you mean to say that in all these 500 surgeries, you don't have a single mesenteric hernia? I said, that is true. It's not through any of the mesenteric gaps. Mind you, we may get an internal hernia, but that is through a band or something else that may have formed due to fibrosis. But honestly, with a good closure, once you've learned this in the proper way, we have never had a mesenteric internal hernia. And probably Alper might vouch for that. Alper, did you see any internal hernia with good closures like this?
Only one.
Okay. So it's as rare as that, because once you do this effectively, so the first thing was to get the purse string at the base to close the base, and then it's a side-to-side approximation. It takes probably 4 sutures, 4 interrupted sutures, and it closes this gap very, very effectively. So there you can see the gap being closed. This will be the last suture. Yeah, so I just wanted to show you this to complete all the steps, the important steps.
Just a comment, Dr. Surendra, excellent demonstration of technique. But the internal hernia is a lifelong complication, and I think not all patients come back to us in our practice. So I think it would be very difficult to say that you never get a hernia from whichever technique or material we utilize.
I understand your comment is, I'd just like to add something here. When you are dealing with a procedure like ileal interposition,
they come back to you.
Whichever surgeon sees it, says, go back to your surgeon, because they don't want to get into an ileal interposition because they think they don't know anything about it. So we definitely get to see any of our patients who have a problem.
This is true.
Sorry, that's an excellent presentation, and I can now understand your dancing with the needle.
Alper's kind. He's a extremely skilled surgeon himself. You should see him operate.
Yeah. No, I think that's brilliant. I think it's quite obvious why it hasn't. Generally, surgeons haven't picked up, because it's more complex, and you need to spend more time trying to do it as well. I think it's interesting. Thank you very much. Right. Any more questions about this procedure, please?
Rui want to ask.
I have a question. Thank you for your great operation, but I think that we can reach the same result with simpler operations such as one anastomosis, gastric bypass.
It's true.
Shorter duration of operation, more simpler to reversal and conversion or revision. I think this procedure is very hard to reversal or revision. My question is, why you choose this operation in all low BMI patients, that you may reach the same result with OHGB, for example.
So I think one important point we all must remember is that lower BMI patients do not handle malabsorption well at all. They'll either have some complications in the longer run, shorter run, you'll get your results and your remission. But believe me, when you follow them up, either they'll have some complications or they'll lead a miserable life with malabsorption and malnutrition. So that is the biggest factor and the reason for choosing this procedure over any other easier procedure to do.
Plus,
Can I just ask another?
I did all the procedures. I can tell you, I did DPD, Scopinaros, DPD. I did one anastomosis gastric bypass, more than 200 patients. I did it. They don't work. The only option that works in the long run is the interposition, because I did it.
And you also know from the BPD data and the publication which was mentioned earlier, that in that lower BMI group, the remission with the BPD DS, which is the strongest bariatric procedure for remission, was about 8% in that subgroup of patients. So what Alper is saying.
Can you tell us,
Rui,
sorry, can you tell us, is there any relapse of your diabetes in these patients?
Oh, yes. Not all patients listen to us at the right time when we advise them for surgery. There are patients on an average, Alper's experience is different because I found the subset of patients when I was in Istanbul and we were operating over there. Patients are more straightforward, and I think it's simpler because they're smaller unit families. In the Indian social structure, there is so much of free medical advice that comes from all the relatives that on an average, our patients come for surgery between 5 to 8 years after we have first advised them. Now, when the patients come later, these are the patients, some of them who have got a poorer beta cell reserve at the time of surgery, these are the ones who are likely to have relapses. Majority of the times we see if there's a relapse, it's very easily controlled with 1 or 2 oral medication. But there are a few who go back to insulin, and our approximate relapse rate is between 3 to 5% in our data. I don't know if what Alper would like to add to that.
The main problem that we had was infection. These people are slightly more vulnerable to colonic bacteria colonization. So we have a group of people who come to us with diarrhea and urinary tract infections. So during these infections, it's hard to handle that. But I have 4 patients with 2 BMI above 30, 2 BMI above 35, in which we have done an ileal interposition, and they came back to us with pure type 1 diabetes. And we couldn't understand the reason why. We did all the genetic tests, but in 4 obese people, type 2 turned into type 1, and we couldn't do anything.
Could there be a missed LADA, or could they be with beta cell burnouts, which...
No reason. No reason.
Okay.
Have you ever revised these patients for any complication, number 1, or on the demand of the patient, number 2?
I've never had to revise for any complication, nor has any of our patient actually demanded that. So I've never had to do anything like that. Alper, did you have any such experiences?
So Suran, can I ask a final question related to something more general important? I know after we discussed this for so many times, how do you think would be your advice to us, for example, for myself and Dr. Abbas, which is my friend, by the way, from Dubai? How can we get the number, and how can we convince the physicians to to get the patient through the door, because as you know, if you do one of these once a year, it's no way it's going to be good. I mean, you need to do this in a regular basis. How do you get the patient on the table? What is your advice? Because this is the key of this kind of session. It's good to see how good you are, how good the guy in Turkey is, blah, blah, blah. How we can expand to the world. What is your advice to me, to us?
So most times we find that there are very few endocrinologists who are open to referring these patients because they all know the science behind this. I mean, they promote the drugs which have similar incretin responses. So they know all these things, but most times they do not refer. So very few people would be helpful. They would refer some. Otherwise, the best is the patients who have been helped by us, who have been operated. They are the main ones who go on referring these patients, and that goes on endlessly, and that is your real pool.
So how can you explain? How can you explain that very few cases are done in India by you or by your other people, and they are mainly done in Turkey or in South America? I don't get that.
So as I mentioned to you, the structure, society structure is so complex that by the time they finish with their family and the endocrinologist, most of them have been convinced either not to get operated, or if they are in the obese group, they go for one of the bypass.
Other operations. Okay.
Yes.
Great.
Sir,
I think, thank you very much. That's been a fascinating and quite interesting discussion. I'm sorry to be a person to cut the discussion short here now. We need to move to the next session. I think we are going to put this all onto the GLR videos as well, so people can go back and revisit it. We're going to hopefully get some time after the next session, at the end of the next session, where we could have more discussion, because some of the questions already been covered, quite a bit of that. So it'll be easier. So can we hold the discussion on till later on, and we'll come back to it. So thank you very much. Imran, can I pass it on back to you again, please?
Sir, so much thanks. And really, it is so much interesting, and especially ileal interposition and sympathectomy. It's my, I will try my best to arrange another session only for this, to understand more and more about pathophysiology of diabetes as well as the surgery. So when you do sympathectomy, have you any comparative study between sympathectomy and without, and many things. So now, because due to shortage of time, we will go ahead, and in this session, we will talk about MGB, OAGB, and Roux-en-Y in low BMI. Because when I interview these legendary professors, surgeons, so some of them, they are doing OAGB or Roux-en-Y, lower BMI with adjustment of PP limb. So in this session, our panelists will be Professor Lee, Professor Rui Rubirio, Professor Karim Sabri, Professor Michael Kramer, and Professor Padma Kumar. And our moderator will be Professor Amir Khan. Professor Bruno just sent a message, so maybe he will be able to join us. And Professor Atif Inam, still he is in operation room and dealing emergency case, but hopefully he will join us. And Professor Chetan Parmar. Sir, please, you can start and with any.
Thank you very much. We're moving to the last session.
I'm sorry, but I have to leave.
Try to make sure that.
Please.
So are you going to leave us?
I'm sorry. I'm sorry for that. It was so nice to have you all.
It's been great having you on the forum. It'd be nice if you could join at then for discussion if you got time at that time.
Thank you very much. Thank you very much.
Great.
Bye-bye.
Thank you very much. All right. As we start this next one now, I'm going to try my level best that at the end of the session, we got enough time to have a discussion and try to recap some of the stuff we've discussed so far. So I think let's quickly move on to the discussions. We're coming to an area which is much more common. RYGB has been there for ages, and similarly OAGB and MGB, although that's become more popular quite recent. So lot of surgeons in the world are doing that. We've got plenty of patients on who have had this procedure done. So, and more people are more familiar with those ones, especially coming on to the lower BMI. I think I'm not going to, Imran, I'm probably going to bypass the definition on those things, but I'm going to mainly move on to selection criteria. Yeah. As it was mentioned earlier, that when you're operating a low BMI, is it better to go for a reversible procedure or a non-reversible procedure? And if we go for a reversible procedure, which one to select? So I think I'm going to start question from, is Professor Lee around? What's your criteria of selection when you are deciding the procedure for patients with a low BMI? Professor Lee?
I can't see Professor Lee.
Because there is now 2 a.m.
All right. Okay. Sorry about it. What about Ribeiro? Professor Ribeiro?
Yeah, Rui is here.
Rui, are you there?
Yes, I'm here.
Yes, I can see you, Rui, now. Please, do you want to start with your selection of procedure when you are picking up a patient with a lower BMI?
Okay. As I said before, my ambience is different because we are operating just people above 30. Because, and this is something connected with the previous discussion, the option for simple operation is not only connected because of some laziness of the surgeons or not wanting to take many risks. It's also because of the experience of the surgeon and also because of regulations. In European countries, they're not allowed to do low BMI, even severe diabetic patients, because there is a risk of medical legal issues that can damage completely our career and our life. So we need to consider that also. And it's important. Fortunately, I have a close friend of Surendra Ugal and Alper Celik and Auri Di Paula. I'm happy because I can talk with them sometimes and we are friends. And but in my practice, it will be very difficult to go for more complex operations like ileal interposition, even without the duodenal exclusion, because, of course, if people are trained and the risks are low, there are still risks, and if I'm not able to justify them, it will be a mess. Anyway, going for your question, for people below 30, I tend not to pay so many attention to the BMI, but more to the severe disease of the patient. And we know that diabetes is the more severe. Alper said it very well. H1 hemoglobin A1C is our marker. I suppose that any patient with H1C above 60.5 or 7 and with organ disease can be a candidate. I would like to use the IMSS score mainly because it can orientate us about the selection of the operation. And of course, OHB is my first selection, has been in the last years even for the low BMI patients. And I learned that from, you remember very well, Manuel Garcia Caballero from Malaga. He was the champion of that. He wrote the first book about diabetic surgery, the one with the blue art front. And he was doing patients even below 30, and he was adapting the operation to the patient. In patients with, I would say, 28, he would go for a somehow larger sleeve and for a shorter biliopancreatic limb. And in that way, he was able to control the diabetic people, type 2 diabetic people, of course, with excluded the LADA and other situations, and get good outcomes. I learned with him to do that, and I'm doing that about the patient between 30 and 35. But I'm doing that for, I would say, 10 years. But I saw some people coming back with relapse of diabetes. So they improved and they came back. And because of that, I tried new solutions. And the new solution that I'm going for is for nowadays about 7 years, is the transit bipartition concept, which works good, which works more similar with with the ileal transposition without the duodenal exclusion, and it's a safe operation, and in my practice, very safe. And we Alper commented about complications, but we are not having severe complications about that stenosis. But I will ask him later what complications we're talking about. Anyway, about that dichotomy between simpler and more complex operations, I would remember that here we used to say, and you know the quote for sure, that optimal can be the adversary of the good. And we are, in the end, we are dealing with a benign disease. It's not a cancer. And we need to be cautious and not, first of all, not to do harm to the patient and try to keep in safe operations more than simple. And we need to remember also that we are not all of us. I am not Surendra Ugali, I am not Alper Celik, I am not Auri Di Paula. I'm an humble surgeon and I'm satisfiedly good, but I need to remember that there are people that are not safe enough to produce other kind of operations, more evoluted operations. Although I think that in the future, with improving of the education and of the surgical training, we can get a better level of surgery. And in the end, maybe in 10, 20 years, all of us, or most of us, will be performing ileal operations like ileal interposition or bipartition or SADS or duodenal switch. But sorry, I talk a little bit. I wanted to say this before, but I took the advantage of being talking now.
Great. Thanks very much. What about Padakumar? Can I put the same question to you, please?
Yes, sir. Good evening. Thank you for involving me in this discussion. Earlier also, when we presented, our policy is anything more than 30 BMI, we offer mostly the sleeve gastrectomy between 30 and 35 and above 35, depending on patient's choice, whether it is a mini gastric bypass, RYGP, or sleeve gastrectomy. Anybody who is lower BMI, we take less than 30 as a lower BMI. And those patients, we offer hybrid ileal interposition. That is the open plus laparoscopic version of the ileal interposition. That's what we practice. For such patients, we will definitely look at their C-peptide levels, then the IA2 and GAD antibody levels. Make sure that they are type 2 diabetes. They may do better because the C-peptide levels are reasonably good. We would prefer to have it at level of 3. Maybe at least 2+ will be our criteria to take these patients for ileal interposition procedures. And though the numbers are less, we have excellent results with those patients who underwent these procedures. Long-term results, I could see even a patient who had this interposition procedure 10 years before. He said this 10 years he is off insulin and is happy. So that is the kind of results which we can produce, but the numbers are not too high to say that these patients are opting for this procedure. But whenever done, ileal interposition is doing very good for patients less than 30 BMI.
Karim Sabri, can I come to you, please? What's your on the same question? Right here.
Good evening, everyone, and I'm happy to be here with great panelists of surgeons. If we have a Banner's index more than 35, we can choose either Roux-en-Y gastric bypass, mini gastric bypass, or sleeve gastrectomy, according to the age and weight, and also according to the educational level of the patient, and also according to the condition of reflux. Suppose that you have a patient with paroesophagus or severe reflux or a huge Hiatus hernia, we can choose the first of what? Sorry?
Sorry.
Okay. Continue.
Okay.
Sorry.
So if the patient have a surgical indication for doing Roux-en-Y gastric bypass, it's good. As I said, huge Hiatus hernia and paroesophagus, the reflux, unless we can do mini gastric bypass. Although of this indicated surgery, Roux-en-Y or mini gastric bypass, if we saw that the patient is underestimating the need for vitamins after the operation, we can refuse all type of bypass surgery and we can proceed for sleeve gastrectomy. This is according to the counseling of the patient. Also, we can keep in mind that the patient, we is concerned that he will have a definitive surgery to cure the whole diabetes, and it's not real. So we have to discuss with the patient his concern. We have to explain for the patient that he may have a relapse of diabetes, and he have to do a stage, a next surgery after that if he has a relapse after that. So we have to keep in mind that we are dealing with a patient that are searching about a definitive surgery for diabetes, and it's not real and it's not present actually. So this is a point. Below the between the body mass index 30 to 35, if I saw that the patient after counseling is agree about taking vitamins, and his commitment is good, and he will follow up with me as regard vitamins and protein deficiency, I can proceed also for one-way gastric bypass 50 to 70, 50 centimeters bilipancreatic limb, and 70 row alimentary limb, and also mini gastric bypass to exclude about not more than 180 centimeters. It's our policy to do like that. If the patient also is underestimating the vitamins, and he is ignorant, and he can't afford the vitamins cost, and also he is not insured to follow up, so I can proceed for sleeve gastrectomy. And we saw that the American researchers, especially the American publications, they said that there is no difference at the next 5 years after the sleeve gastrectomy and Roux-en-Y gastric bypass. There is no big difference as regard the comorbidity resolutions and also the diabetic remission after in the next 5 years. But there is a little difference between the weight loss, but they recommend also to and they still investigating the difference between Roux-en-Y and sleeve gastrectomy. So I see that if the patient is not educated enough and he cannot not afford the vitamins and the follow-up, we can proceed for sleeve gastrectomy. Also, as regard, we want to avoid any legal problems, so we avoid any type of surgery below 30 because it's not supported by any guidelines as well. This is my opinion as regard this point. Thank you.
Thanks. Michael, can I bring you in and just change the question a little bit as well? That if you had a choice of between MGB, OAGB, or Roux-en-Y, what criteria do you use to differentiate which operation to get the patient?
You asked me? Yes.
Yes, please. Yeah.
Yes, sorry. So just to introduce myself, I know Rui for many, many years. I'm so happy to see him, and I'm so grateful for Imran that he invites me. The funny story is that I'm really a sleeve guy in the bypass group. So,
all right. Okay. Sorry.
Yeah, and I'm really a Zazi guy. So I think this is much better, this question to Rui, for example, who is doing a lot of MGBs and who has much better criteria here. So what I just can give from my side, I'm a little bit a lost soul in the space because now I'm moving to Central Asia, or I was moved 18 months ago, and we build up now here a metabolic and bariatric center in Tashkent, Uzbekistan. I was before active in Munich, so I'm not active right now, and I'm really interested to listen to your discussion with the ileal interposition, because I really believe in these ileum hypothesis, and I can see really a lot of effect. And maybe that was the idea from Imran, because when we spoke in our interview, I say, this is a small comment to the bypass group. When I see people with bypass and problems, but this is not so much connected with diabetes, maybe this is not the right topic here, I do the ZAYI. So if you bring the food a little bit to the distal ileum after bypass, I see very nice results, but these are preliminary studies. This is not officially published right now, but I see this power of the ileum. And this is maybe exactly what all of you told us before. And this is just my comment, that in the low BMI, we have to be very careful, because what I see is sometimes we are too strong with what we do. And that's why for me, it's very important that all our procedures are almost reversible. And I would only recommend to do surgery in close connection with my diabetes experts. So this is not in my hands alone. So maybe like a metabolic board, this is something what I would recommend, that we say, okay, we do it together. because this low, and in Europe, Rui pointed out very well, 30 is the border, but in Central Asia, 27 is of course more possible. But right now I'm really careful, but because the patient has to be happy and his diabetologist as well. So this is my comment. So back to all the bypass experts.
Good. Rui, can I just bring you with that question, that when you are selecting, if you've got a choice of both, either do a MGO OAGB or do a Roux-en-Y, how do you decide which one to do for which patient?
It's not difficult because I'm performing OAGB for 12 years. So, and I'm pretty convinced that it's a better operation than the classic Roux-en-Y gastric bypass that I was performing from 20 years, but I changed into around 2010 to the concept of OAGB. And OAGB is clearly better, and there are more performances. Somehow it's reversible, it's revisable. We can adjust to different kinds of patients. There are less problems with hypoglycemia, less problems with internal, and so there are advantages for the patients that we don't have with Roux-en-Y gastric bypass, the classic one. So I quit from Roux-en-Y almost, except for patients with Barrett's. It's my only indication for nowadays to do a small pouch. In all the other cases, I do a tailored approach, making a person. I measure all the bowel. I suppose that is essential to have good outcomes with OAGB, or even with Roux-en-Y gastric bypass. The way I do it, you know, the diverted OAGB or long pouch gastric bypass. For those patients, it's nothing to see about diabetes. It's for patients with risk of reflux, mostly revisional cases after sleeve or after band. I saw a lot of reflux in those patients, more than in the primary cases. So I try to avoid and to keep patients away from that phenomenon, reflux, that is very, very uncomfortable for the patient and for me also. And so if people have reflux or risk of reflux, I go for a diverted OAGB. If no, I go for OAGB. But in both cases, I make the tailored approach, making variations between the biliopancreatic limb. And I'm not so economic as people are saying nowadays. Usually nowadays people are doing OAGBs with 150 of biliopancreatic limb. I suppose that at least for our patient in Western Europe, it's short. And I use a rule about the percentage of the total bowel weight length. So something like that. People between 30 and 35, I would go for, I would say 120, maybe 150, depends of the presence of the other pathologies. If it is a severe diabetic, severe dyslipidemia, hypertension, whatever, sleep apnea, I can go some more centimeters. But 30, 35, I go for 120, 150. 35 to 45, I go to 30% of the total bowel length. Up to 40, 35, 40, 40%, up to 50, sorry. 50 to 60, I can go to 50% of biliopancreatic limb. And it's enough, because even in shorter bowels, if it was able to go up to more than 50, it will be enough to absorb well the macronutrients and the micronutrients. And eventually in MegaBs, I can go up to the limit that is the concept of Bagua from Carbajo, which is to perform something like 60% of biliopancreatic limb. So, but for diabetic people, I try to be more extensive, because I learned that also from Carbajo and Carvalheiro, that if you go a little bit further away, like in revisional cases also, after sleep, for instance, we need more power. And the power here is connected to what Michael said, to put a little bit of food ahead in the ileum, to stimulate the ileum, to stimulate not properly the GLP-1, but probably the PYY and the FGF19, like Santoro likes to say a lot. And that incretinic effect will be more important. And mostly that stimulation, having together food And bile, what Santoro calls the alloileum theory, will produce ileal hypertrophy. And with hypertrophied ileum, there will be more incretins and more also, and long biliopancreatic limbs have also the advantage of absorbing, that is proven nowadays, more bile to the blood, and that's very important in order to get the good metabolic effects that you know. So that's more or less that. I adapt the bowel length to the patient according to mostly to the total bowel length, not the BMI, and the pathology of the patient.
Great. Chetan, you want to please come and explore a bit of technical bits now?
Thank you. Thank you very much, Ahmed. Thank you, Rui, Michael, Karim, and Dr. Padma Kumar for this discussion. Coming to the technical bit, I think we all talk of the limb lengths, and I can gather already that people are tailoring. But if you look at the literature, people also tailor their pouch size. And that was my question here, that let us say patient with very low BMI diabetics, do you make a wider pouch? I know we all say for mini bypass, we all make long pouch, but do you make a wider pouch to compensate for the dietary requirements? And similar in Roux-en-Y, would you make a wider or a bit longer pouch to a normal Roux-en-Y where you have a tiny pouch? So yeah, Michael, I know you mentioned you are a sleeve surgeon, but would you say you would make a broader or a wider sleeve?
Oh, yeah. I think, first of all, we have to think about what is the problem of our patients. Is it really that they eat too much? No, because then they would have a higher BMI. And that's why I think you are right. I think restriction is not what they need. I think this group, and this is need metabolic components, like Rui pointed out. I really believe in GLP-1, PYY, and I think this is very, very important. And so for this low BMI group, I don't think we have to make it smaller or tighter. We have to make it very metabolic. And this is exactly what I have learned tonight about the results from India. This is really interesting. This is, for me, exactly what I see. For me, the same feeling is it's a little bit too much. Yeah, this is my feeling, but of course the results are right. But I think to make it smaller is not the solution. I do, for example, endoscopic suturing to make outlet repairs. I'm not happy with all these results so much. So what I'm happy with these Zahi, when you bring more GLP-1 in this patient. And this is my question to all of you. What do you think about, because now we have this medication, before we do surgery for low BMI patients, do you think it makes sense to go with Saxenda or medications like this to see very much in detail, is this surgery a good approach? This is my first comment. And the second one is, Rui, when I see these patients with failure after bypass, I see exactly what you pointed out. I see a very, very long, small bowel, 8 meters and more after the anastomosis. And if you make this long, small bowel shorter, the distance to the terminal ileum, you have these wonderful results. That is just my comment, what you mean by measuring the size.
Yeah, about the first point, I suppose that Edward Mason had already that idea many years ago. Where I tried to make a test, a preoperative test, giving hormones to the patient and look at the outcomes. And if it's positive, he can predict that the outcome will be good. But I don't agree completely. Let me explain why. Look, you are giving with the liraglutide or other one drug that you give in an injection that will go to the fat tissue and that will be released in a constant way through the day for 24 hours or 1 week. And the biologic rhythm is completely different. We are producing a dozen incretins, not one. And there are cycles of production according to the fasting or according to the meals that we are having and to the stress that we are having in the day. And that is completely different. So I suppose it's predictable. completely with that kind of tests. And indeed, I'm using a lot the GLP-1 analogs to prepare patients for operations, mainly the super obese or people very metabolic with very round bellies with big livers, and some of them they work good. I mean, the outcome is predictable, but some of them is not. So it's not a good hint, I suppose. The other questions, what was about the bowel length? Okay, yes, I agree with you. Sometimes I provide patients with OGB because when I go to the gallbladder, I take the advantage to in all the cases when I was not measuring and to measure, and I found also long common links. And of course, that's one of the advantages. If you have a patient with a failed OHB, failed is not a good term, with a recurrence of weight in OHB, you can elongate the biliopancreatic limb. If it is sufficiently long, you are going to get a weight loss again, because you're going to put the food more ahead. And you're going to change more the microbiota and so on. About the sheet and question, about the pouch. Well, OHB is a very comfortable operation in my hands because my patients usually don't have vomitings in the postoperative period because I don't do a very narrow tube. I do it narrow, but not too much. And it's always the same in low BMI or larger BMI. But I know that they need certain amount of restriction in order that at least in the beginning, not eating a lot. And more than that, if you make a larger pouch, not narrow, in the future it will dilate more, and the recurrence of weight will be more prone to exist and to happen. So try to keep it in my concept. Comfortably slim, I would say. Comfortably slim is our measure. And look, that is very clear for the ones that are performing transit bipartition, OATB or SASI, that a good SASI or a good bipartition depends a lot of a good sleeve. If you perform a SASI with a large pouch, it won't work good. And I had that experience. I had 2 patients that I have done a little bit larger, and they didn't lose as many kilos as I was waiting, and I had to go for application like Amir is doing, and they have got the weight loss again. So certainly slim pouch is necessary, but not too slim, at least at the point that they won't vomit.
In the same line, then, we have talked of that. Would you alter the size of your gastrojejunal anastomosis, either in OAGB or in the Roux-en-Y? Dr. Padma Kumar and then Karim. For low BMI diabetics, would you change your gastrojejunal anastomosis size?
Yeah, as we were listening, 2 things. One is whenever we are doing for a lesser than 30 BMI, the sleeve itself is a modified sleeve gastrectomy. Maybe we will have a little more of a space left because the restriction component itself we are actually modifying. And whenever we are doing the interposition also, it's not that 100 or 200 something. What we do is measure and make it midpoint as for the ileum jejunal transposition. That is number 1 point regarding the interposition. When it is a MGB procedure which we are doing, we are not actually restricting the size of the pouch as such, but the limb which is we use for bypassing is limited depending on the BMI of the patient or the level of diabetes, maybe from 150 to 250 centimeters, whatever we need, depending on the BMI of the patient as well as the metabolic status of the patient. Regarding your last question, like whether you leave little more of a space with the gastrojejunectomy, not really. Actually, we usually give only just maybe 3 or 4 centimeter of gap for the gastrojejunal anastomosis. That is not made too wider.
Thank you, Professor Sabri.
Yes, so if we have also again BMI index more than 35, we are, as usual, we are doing the pouch 36 bougie. And also we have to exclude not less than 2 meters if we found that the common channel is satisfactory and it's safe for the patient. If we are talking about the body mass index between 30 and 35, we have to tailor the operation. Yes, I'm trusting in restriction and also the size of the gastrogenostomy more, because we have the definition, the new definition of obesity. It's a multifactorial disease. It's genetic. We have a hormonal adaptation, and we have gut adaptation. We have so we have to do a restrictive thing for the patient, that restrict him from eating more and to prevent his weight regain in the next few years. So I'm trusting in doing a restriction as if we are doing MGB for a patient above 35. So we are doing in our techniques, we are doing 36 French bougie pouches. And also in Roux-en-Y gastric bypass, I'm trusting also in restriction as if we are doing it for a morbid obese patient. Also 3 centimeters, I see in my cases that 3 centimeters gastrogenostomy is more efficient and more realistic, more than doing a gastrogenostomy more than 6 centimeters or 5 to 4 centimeters. So, but my modifying, if I want to modify anything, I want to modify and to be concerned about the bowel length, and not more than 180 centimeters, not less than this, because I feel that if I'm doing more than this, we will make the patient to be fail in the next few years. So I'm trusting in restriction, even if we are working on the low body mass index patients, not more than 30 body mass index. Thank you.
Thank you. And I had a.
By my part, can I?
Is it okay to answer a follow-up question to this thing? The reason I was trying to talk is, there is a lot of discussion now about TOR, transoral endoscopic reduction, outlet reduction operation. So there are a lot of publications saying, oh, you should make the opening tight, 1 centimeter, 1.2 centimeter and stuff. So looking or listening to these 2-3 experts here, I think everybody thinks that 3 or 4 centimeters should be your normal GJ anastomosis and rather not narrow. Then the question is, let us say this low BMI diabetic patient comes back after you have done your OAGB or Roux-en-Y, comes back with either relapse or weight regain. Would you say that you would go and do a TOR on it, or do you say there is no role of TOR in those scenarios?
Well, can I?
Yeah, Ari?
Before that, I just to complete the answer, usually I do the anastomosis with 3 centimeters. Before I was performing 2 and 250 centimeters for the anastomosis, but I had a couple of stenosis. I don't know why. So nowadays I do 3, but in certain cases, 3 cases mostly, and this is the case, low BMI patients, because they need to eat more in order to not to lose so much weight and fat mass and so on. Revisional surgery, because there is a tendency for more fibrosis and maybe more stenosis. And people, which one? Okay, those ones. About your questions. Well, if I learned something from 20 years of practice, more than 20 years, is that which kind of restriction we can put on the patient, it will fail in the vast majority of the cases. So restriction is not the best way to deal with this disease. Restriction is the disease itself. So try not to be too confident about that. Of course, as has been very well said here, diabetes or obesity is a clock ticking. So everything is coming back. There is a tendency to go back. And of course, if in the scenario that you have put with the OAGB, like Roux-en-Y with the pouch dilation or anastomotic dilation, the endo restriction can work, at least for a while. And yes, I can consider that, because in my understanding, we should use all the weapons together: surgery, endosurgery, medicines, behavioral therapy, everything is useful for the patient and for us.
Thank you. I can see Dr. Karmana Saravi is here. Mohammed, do you have experience of TOR? Or in that scenario, what would you do?
For weight regain after low BMI. Chetan, please,
You know, it's the low BMI patient, if you've done OAGB or RONY, if they come back with weight regain or relapse of diabetes, would you recommend any transoral outrage reduction endoscopic procedure or no? Do you think there is no role? It looks like we have lost.
I have no experience about this procedure in Iran. But maybe we choose a longer BPR and or destabilization in low BMI patients after relapsing, such as the same as the higher BMI patients.
Thank you. Dr. Amir Khan, back to you if you have any follow-up.
Yeah,
thanks very much. Yes, sorry, you wanted to add something, Padma?
Yeah,
Can you hear me, Chetan?
Yeah, what we usually give is like if it's an interposition patient, if they have a relapse, we try with this semaglutide kind of medicines. If it is sleeve and if there is a regain in weight or if there is a relapse of diabetes, we try to convert it into a mini gastric bypass. If it is MGB done or if it's an RYGB, it can be converted to larger limb length. Very rare occasions only we have sent them for a endoscopy procedure.
Lauren, you wanted to add something. You came in.
I think Lauren, you were saying something. Yeah.
No, because your question is interesting, but you cannot compare. First of all, you cannot compare what you do with a relapse after MGB and a relapse after an urinary gastric bypass, because after urinary gastric bypass you have very limited option. So perhaps these options to narrow the pouch on top, which I don't think it will work, it's an option. But the advantage with the MGB is you can always convert to a urinary gastric bypass or elongate the limb. So you cannot compare orange and apple. It's a very different story. You know, it's a so different situation. And I believe this action on the top, I can call, you know, when I call on the top means you got the top and you got the bottom, right?
Yeah.
On surgery, the action on the top for relapsing diabetes problem, I think is not going to work.
Yeah, the reason I'm asking Lauren, the way endoscopy, you know, every day these days you see paper and paper out for endoscopy.
Yeah, but let's put
I think we are going to face that.
Okay, let's put the thing this way. If I was going to go for it, I will action to the urinary bypass on top, and I will action surgically for the MGB, because it's a lot easier to manipulate the digestive system, right?
Okay.
I'm sure you agree.
After an endoscopic procedure, and we need to have, I need to have always an exit strategy. If it doesn't work, what are we going to do? Surgery following the endoscopic future failure. And if you are going for new surgery, you are going to have anchors and metals in the gastric wall, and that can be another problem for you to solve in the revisional surgery.
Yeah,
that's
I think Chetan, your question was right,
before,
but I think
before I go, sir, I would like to have one little comment to my friend from India. I believe if you have a type 2 diabetic patient from 26 BMI, let's say 25, 26 to let's say up to 35, because this is what we can do this in the UAE. I please don't offer them a sleeve. That's it. It's for whatever bypass you want to do, whatever you are, MGB man or Y bypass man or SADI man or SASI man, or like my friend in Dr. Abbas, he does in Pakistan, he does a very good job. But a sleeve, it's no. Forget it.
Yeah.
That's it.
Yeah.
It's not going to work.
Yeah, I think I'm going to, as we're coming almost to a close soon, we're going to
Yes,
ask Chetan to try to give us some, put things into perspective as far as the research and the papers are concerned to help us to understand. Just one more comment before we move on. For people with the lower BMI, should you be doing a non-reversible procedure?
Well, I think it's depend, my friend. I mean, you're talking about what? You're talking about no, everything. Remember, my dear, everything is reversible, right?
No, sleeve.
Let me tell you, everything is reversible in surgery.
I think
Amir is pointing, Amir is pointing
just
towards
give-
sleeve, Lauren. He's pointing towards sleeve. That would you just reset? That was correct, Amir?
Yes.
I don't understand. This is
Because
very.
if you see,
please tell the question differently.
No, I'm just trying to put it. I accept your point, but I think the thing is that if someone with a low BMI,
yes,
and you're operating on them,
with diabetes,
yes, should you be doing a procedure like sleeve, which is non-reversible or not?
No, you should do to this patient the operation which is going to be the most likely successful for your patient. Sleeve is not going to work. Full stop. Don't do that. It's a huge mistake.
I agree with you on that point.
We have a
I agree with you on that point, but I think I'm going to leave that for a further discussion.
We have actually published data.
Don't do that. Don't do that. Don't do that.
Yeah, but we have our data which is showing
Well,
very
you
good.
can do whatever you can tell me,
20 to
whatever. I
35
know you,
BMI.
Baba. I don't tell you don't do that. Full stop.
Yeah, maybe it's your
Lauren,
opinion.
let Padma complete his sentence.
I
Yes,
know,
please,
but
Padma. Yeah. Padma, please complete it. Yeah.
Yeah, what I was telling is we have published data where the body mass index is 30 to 35, and we have done sleeve gastrectomy with long-term follow-up, and we have good results in our population. More than 35, we give them option of a bypass or something, because in our opinion, a procedure which is reserved is RVGB or MGB, which should be used for patients who actually get maybe if there is a relapse of diabetes or obesity. So that is what 95% of them will not require any procedure like a bypass or a RVGB or MGB. Sleeve will be sufficient. That is our thought on it.
It is all rubbish, my man.
Yeah.
So I think don't say rubbish. It may be your opinion, and we value your opinion on your perspective. But you cannot say a procedure which we do with excellent result as rubbish for seniority.
No, I'm not talking about you, man. I'm talking about. I know.
It's not right.
No, I think we need to understand from everyone's perspective.
Yeah.
And the main purpose of these forums is to have a discussion and then try to give some sort of a guideline to youngsters or upcoming surgeons or people who don't have access to all that literature, to at least make sure that they make the right decisions. What I want to do is, as we are coming almost to an end, I'm going to request Chetan. Chetan, could you please help us to give us summarize the session, as well as help us to understand what the literature tells us, please.
Thank you very much. Again,
Chetan, I want to add one thing as Professor Amir Khan. So this is the best time to understand patient selection, because our target is low BMI. That is most important. So we must define low BMI according to international data, and because we must follow international guidelines as well we have, and also how we can select this patient selection, then okay, we will go for technical points. And so we need your support. Muhammad is here, and hopefully at this platform, we will be able to do some consensus or guideline, especially low BMI diabetic patients.
Exactly.
Okay, Chetan, floor is yours.
Yeah, no, definitely. I think that's a learning process. You can see here, Imran, I'm making notes for that already. So Yeah, so coming to patient selection, actually, I think everybody should be now aware of the new IFSO ASMBS guidelines. And if not, for young surgeons out there or who are just starting, I think it is worth reading it because they have reduced the BMI criteria for eligibility by 5 points in all different levels. So everybody should be aware of it. It is a free access paper, so you don't need to buy it. They are freely available on Facebooks and internet and Twitters everywhere. So please read that for the young surgeons out there, because that is going to affect this low BMI operating criteria, because we are talking of 27.5 here. I think according to those guidelines now, even 23.5 BMI patients will become eligible in the certain ethnicity and all. So I think it is worth highlighting that. Coming to literature of MGB and Roux-en-Y, the good thing compared to when we initially talked of SADI and SASI and all, there is plenty of literature for Roux-en-Y bypass where they have compared low BMI to high BMI and also low BMIs with diabetes and all as well. So, and it has shown long-term promising results as well. So that is good. If you talk of mini bypass as well, yes, mini bypass relatively is a younger operation compared to Roux-en-Y, but there are some long-term data, including 5 years and 10 years data. If you look at, I think 5 years data, there are more compared to 10 years data. 10 year, I think there is only Carbajo and a couple of other 8-year follow-up. But 5 years data with mini bypass are now plenty available, and it's a good metabolic operation compared to Roux-en-Y. Well, that's what the current literature is showing, including if you look at big RCTs like Omega trials and all as well. But again, that those big RCTs don't really focus on low BMI. There is one trial from, I think, Vijay Lee, who had compared it in low BMI, and they have all tailored their BP limb. I think we all talked about tailoring of the BP limb. So for low BMI, to be on the safer side, I think tailoring and having a shorter BP limb is what the literature shows. There are some head-to-head comparison between mini bypass and Roux-en-Y bypass papers as well, where not necessarily they have gone to the very lower BMI, but they have stayed around 30, 35 BMI. And both operations has its own advantage and disadvantage. So I think both operations are good for metabolic effect in the low BMI cohort. Briefly touching, I know this is more of MGB and Roux-en-Y session, but I think because Lauren touched on the sleeve point, well, at the moment, the big RCTs, if you look at sleeve pass and the other RCTs, they have shown that at 5 year, the data between sleeve and Roux-en-Y is comparable. There is no comparison between mini, but sleeve and Roux-en-Ys are comparable. I think there is one meta-analysis looking at Roux-en-Ys and sleeve, where they have shown that the metabolic effect at long-term follow-up is better in Roux-en-Y compared to sleeve. But if you just look at retrospective and case series and all those comparisons, there is there, but there is a lot of heterogeneity in that.
But Chetan, if you compare sleeve to Roux-en-Y, of course, Baba.
I agree with this. It's all the RCTs.
It's so obvious.
Long-term RCT comparison. Otherwise,
low BMI diabetic patient. It's obvious.
The trouble is the long-term follow-up data.
Yeah.
That's where we all struggle. That we all have 2 years data and 3 years data.
No, I know, but you know what I'm talking about. Yeah,
it's tricky. So
yeah.
I think that's what
I think for
the MGB and Roux-en-Y are good operations for low BMI diabetic as a metabolic operation. And
on top of the fact that my colleagues,
MGB is better.
In fact, the professor from Pakistan, he was very right. I mean, at least MGB has a reversibility aspect, which we don't use almost never, but he has a point.
I think about the new consensus statement, we should consider about 2 different aspects. One, patient selection in lower BMI that I think it has been published by IFSO ASMBS statement position. But another important aspect is procedure selection in low BMI patients. I think it's more important aspect in low BMI patient, procedure selection in low BMI patient.
Great.
Thank you. So, Amir, that was it. Amir and Imran, that was it. You want more?
Great.
I think that should be enough of the
Good.
lecture.
And I think, thank you very much. Before I hand over to Imran again, I think it's been great. I must say thanks very much to all the participants. I'm sorry, sometimes we had to cut the debates short because of the time constraints, because I think some of the debates we can have afterwards over a drink, but unfortunately this is virtual. So usually that used to be the best part. That used to be the best part of all these meetings, when you can sit down. So I'm sure I'm going to some stage push Imran that we organize a meeting which is not virtual but actual face-to-face, where we can all sit together. And I think these discussions, to be honest with you, are so useful. I've learned a lot out of today, at least sitting down here, and I hope everyone has enjoyed it. This will be available on GLR videos, so people can go and revisit it. Hopefully, we're going to carry on with these type of sessions in future again. So thank you very much for everyone. Imran, I'm going to hand over to you. Thank you very much for organizing it and inviting everyone to participate. Imran, please.
Sir, so much
Dr.
thanks. Really.
Yeah, Dr. Man, just a second before you conclude, because Dr. Amir was telling about physical meeting as well. In Kochi, that is Kerala, south part of the India, we are organizing the Obesity Surgery Society's national conference. Maybe just 1 year from now, that is February 7 to 10. All of you are welcome to attend that 4-day physical meeting with lectures as well as live surgeries. So please, all of you, please join us at Kochi for OSICON 2024, February 7 to 10. I'll put the invite, all those in this group, and most welcome, all of you.
Thank you.
Fantastic.
Sir,
Thank you.
definitely, sir.
Okay,
Yeah,
Imran,
please.
with your permission, I will take an opportunity to announce that Pakistan Society for Metabolic and Bariatric Surgery is also organizing a conference next month on 17th and 18th of March. And I, on behalf of the society, invite all of you, all the members of GLR to physically attend the meeting. We can send a visa letter, whosoever wants to attend and facilitate the process. And GLR will be having a session in it as well. And Dr. Imran will be soon announcing that in a couple of days, the time and the date of the GLR online and physical meeting in the conference as well. Thank you very much.
Fantastic. Thanks.
Thank you, Tansir. And Tansir is our managing director of GLR, and definitely with his support, we are doing a lot at this platform. And Sir Amir Khan, really, with your guidance and your leadership, we will go ahead. And this is a great idea, in my opinion. We can arrange such a sitting in Dubai that is also easy for our international colleagues, and Laurent is so much happy. Definitely.
Yeah, perfect idea.
Yeah, perfect. Very soon, I will also talk with Tariq Mehdi, and because this will be first international conference about metabolic surgery in low BMI. Still, there is no such. Yes, we talk something like this, but we must talk more and more. Then we can mature the type of surgery. We can standardize patient selection. In my opinion, that is the most important. So when we define BMI, because personally I am doing this, and really I am facing issues. So all patients, they don't respond. Then patient expectation is more. So then they just think, so I will do surgery and everything will be fine. This is not like this. So yes, same patient, same C-peptide, everything is same, but response is different. So this, we must know more and more about this pathophysiology and need to involve such legendary bariatric surgeons. So we need such sittings online and physical. Then we can, and also my humble request to Professor Muhammad Kerman Sarawi, who is also our research director of GLR, and Professor Chetan Parmar as well. So just at this platform, and you can also add many others. So if we can give some message to our youngsters, to our society, especially, yes, Mohammed highlighted, there are some guidelines for patient selection, but again need. So which types of lab test we need? Just as Alper mentioned, their criteria is totally different. He's not doing only C-peptide. So there is also stimulated C-peptide, stimulated insulin. What is the rule? So how can we select? How can we predict? So because this low BMI, really very risky patient, because personally I am doing now. So when you select the patient, how you select, then there will be less chance of failure. So definitely we need your support. And again, with your support, all of you, so this GLR is providing these services and also platform to our youngsters. So for sharing knowledge. So my thanks. And soon we will start another session of interview, redo surgeries. And also then, because that is also a difficult topic and a long topic. So just imagine, because we have a lot of things to hear more about this. So because always we invite someone who are expert of in that specific field. And in my opinion, this interview is at least 5 years ahead to the text. So now just when I am talking with Laurent and he is sharing his experience. So just imagine this experience will be paper, then it will be text. It will take time. But now with this, due to this availability of social media or technology, he's sharing his knowledge. And so my thanks again. And I will also share in this group GLR ebook. So my humble request. So you must add your videos. You have your access. You must be author of this book. This is amazing. With the help of a Malaysian company, I will share now. You have access. You will be author. You can add your short videos, your short text, and then so viewers can be so they have access to your technique. Sir Amir Khan, please. So just your closing comment, and then we will ask them.
Great. Thank you very much. All those who are not going to sleep early, come and meet me at the bar and we'll have drinks together then. All the best. Enjoy yourself.
Bye-bye. Thank you so much. Thank you so much.
Thank you. Thank you very much.
Thank you, Imran, for organizing that. It takes a lot of hard work. It takes a lot of hard work for this.
Thank you.
See you tomorrow, Baba. Okay, bye.
Thank you very much. Thanks, Imran. Thank you, everyone.
Masalam, masalam.
Thank you.
Salam alaikum.
Good Hafiz.